All right, class, let's get into a really great drug here. This is the one, if you're in pain, you definitely want to have this. And we use it a lot in EMS, and there's some times that we should use it, we don't. And there's some times that we use it, and sometimes we probably shouldn't. Of course, we're talking about fentanyl, and fentanyl is a great, wonderful drug, great for taking away pain. The sublimazine Sublimase, Duragesic is some of the names that you might see it under. But again, it's used for pain relief as a simulating the opiate receptors. Okay, so it's a synthetic drug. It's a short-acting, rapid-onset opiate agonist. It works very well to stimulate the receptors. Okay, and again, it's an orthogonal agonist. It works along with those receptors, and again, it's an analgesic. It takes away pain. Okay, now again, similar to morphine and meperidine, it has its respiratory effects, except that for healthy individuals, return to normal more quickly. So if you're on a fentanyl, again, they're going to recover from it a lot faster. But it has 80 times the analgesic properties of morphine. So again, if you're going to give something for pain, morphine, again, micrograms of fentanyl work great. Okay. So again, little hypnotic activity or histamine release. So you're probably not going to have any type of reaction to it. They usually don't vomit like they do with morphine. Morphine's got a history of vomiting. Now, it's kind of ironic, though, because usually when we give fentanyl, we usually give a little bit of Zofran. And that is to prevent any type of gastrointestinal effects. Okay? So usually 2 to 5 minutes is your onset. And you want to give this drug a little on the slow side. Slower is better. Dilute it just a little bit. I usually put it in whatever my volume is that I'm going to give. I usually give it in 9 more cc's. When I mix it up, I'll draw up my 100 of fentanyl, squirt out a cc of a flush, draw up the 1 milliliter of fentanyl into a 10 cc syringe. So I've got 10 micrograms per milliliter. It's a lot easier to control that way, and you get a little bit more drug going in. It usually lasts from somewhere between 30 minutes and 2 hours. Kind of depends on the patient, what their activity level is, what's going on with the patient, how much pain they're in. Again, if they got too much pain going on, you're probably going to have to repeat the dosing. So it's good for burns, chest pains, crush injuries, amputations, fractures, dislocations. If they're hurting, this stuff works great. I also like to use it when I'm performing a medication-assisted intubation. I truly do prefer this because, again, it takes away the pain, and it helps augment my other 2 drugs, which is succinylcholine and usually etomidate. So, or etomidate or Versed. So it helps that effect. And again, once I sedate them, by the way, for continued sedation, I usually my kind of preferred thing is a fentanyl Versed drip. It works really, really good to maintain sedation. Again, side effects, sedation. That's what it's kind of supposed to do in a weird sort of way. It can cause some weird vertigo, mood changes. You can get a psychological dependence on it. And again, you can get, however, it will drop blood pressure. It will also do the opposite, is you can get a rebound hypertension from it. Usually the bradycardia is because they quit breathing on you. So, and the other one is if you give it too fast, you can get chest wall rigidity, which will not respond to a neuromuscular blockade. So when you're giving fentanyl, slow. Give it slow. You don't want to freeze up the chest. And I will tell you, the first time that you get one of those, you're going to be scared to death because it's very hard to ventilate those folks. And again, you're usually got about 30 minutes of doing that, okay? So, again, your apnea, respiratory depression. By the way, if you give them succinylcholine, or even if you go as far as to give them vecuronium, they're probably not going to come out of the chest wall rigidity. So keep that in mind as you're giving your fentanyl. All right? Again, it can cause, again, with any opiate drug, again, it can cause constipation. That's kind of a big one. And the other thing is it's going to make the pupil small. Okay, meiosis is making the pupil small. Now, again, if they're allergic to it, obviously don't give it to them. If they've got severe hemorrhage, you got to really be careful. Shock, you got to really be careful. If they've got head or abdominal pain, which is undiagnosed, okay, and even the abdominal pain one, I'm kind of sort of, kind of. If you don't have a diagnosis, if you do have one, you can pretty much safely use it. What they don't want to do is you give it to somebody in a shock state. That's where you're going to have some problems, okay? They've got myasthenia gravis. Use a caution with head injuries. And if they've been on MAOIs for the last 14 days, probably not a good idea to give them it and cause a severe reaction. Now, again, can potentiate CNS depressants, okay? Well, if we're doing a drug-assisted innovation, I think that's what we're kind of gunning for. So your MAOI inhibitors, they can precipitate a hypertensive crisis. So again, really bad reaction to those. You can send the blood pressure through the roof. Not what you want to do. Again, guys, remember, if you've got a breathing problem, again, you can cause profound sedation. You can get the low blood pressure, so be careful. Phenobarbital, thiopentol. You guys want to? It's very incompatible with it, so don't mix it with those. It's a Schedule II controlled substance. You gotta account for every drop of this stuff. Okay. So again, chest wall rigidity when you push it too fast. I guess you're going to see that later on because again in your test, because again that's one of the biggest side effects. Give it slow, dilute it out, give it slow. Okay. And again, use cautiously if with the older patients, COPD. Remember that it is processed in the liver, so if they got liver disease, hold off. It's eliminated through the kidneys, so again, the dialysis patients got to be careful with it. I usually cut my dose in half. Now, a lot of protocols around here have 1 microgram per kilogram. Usually your standard dose, cardiac-wise, is usually you start out giving 25 grams and you titrate to the effect. And usually they'll say 1 microgram per kilogram. Guys, I can tell you, days at Shands, 2 to 3 mics was kind of, and they were extremely liberal about give them more. Okay, especially if they've got a pain source. If they've got a burn patient, 3 mics per kilogram as you're calling the doc to probably get more. Okay, so again, the thing is to watch it. Watch your patient. You're wanting to get the good pain relief effects from it. All right. 2 to 12 years old is usually 1.7 to 3.3 mics per kilogram. 1 mic per kilogram is also acceptable. Usually, again, with the little guys, I start out small on those, and I kind of work my way till they feel pain relief. And again, slow IV push. Very slow, okay? Very, very slow, guys. Don't get that chest wall rigidity, all right? Really, really, really important. Okay, so again, that does it for fentanyl, and I'll see you guys on the next video.